Yeah, Dr. Hinal, can you share your slides?
Yes, sir. Is it visible, sir?
Yes, yes, visible.
And am I audible?
Yeah, you are audible.
Yes. Okay, sir. Thank you, sir.
So, uh, Dr. Asta, can we start?
Yeah, sure, sir.
Yeah. So, 1 minute. Okay. So today's session is on approach to hyperkinetic movement disorder, and Dr. Hinal, and followed by there will be session on dystonia, and uh, Dr. Dhanya will present on Korea. So I welcome everyone, and Dr. Asta is today's moderator, and okay, Dr. Asta, we can start.
Yes, sir.
Yeah,
Should I start, sir?
yeah, Dr. Asta, you can introduce yourself. Then Dr. Hinal and Dhanya, then we can start.
Good evening, everyone. Myself, Dr. Astha Bansal. I have been assistant professor in GB Pant Hospital in Mamsi, Delhi. Currently, I am working as a consultant in Delhi. So, I hope that today we have a good academic discussion on approach to hyperkinetic movement disorders. Dr. Heenal?
Yes, ma'am. Good evening, ma'am.
Good evening.
Uh, I'm Dr. Hinal, third year resident at Pune Hospital, Pune. I'm going to present today approach to hyperkinetic disorders and dystonia. Dhanya is
Good evening, everyone. I'm Dr. Danya. I'm a third year resident in Apollo Hospitals, Chennai. So today I'll be discussing the approach to polio in the later session.
Yeah, we can start.
So hyperkinetic movement disorders are also called dyskinesia, which are characterized by abnormal, often repetitive involuntary movements overlap to normal motor activity. The major five categories are chorea, dystonia, myoclonus, tics, and tremors. They could be jerky movements or non-jerky movements. Jerky includes myoclonus, chorea, and tics, and non-jerky are tremors and dystonias. So, a clinical approach to recognize various dyskinesias. First is the immediate impressions. So, in these four things, we see whether the movement is rhythmic or arrhythmic. Rhythmic as in tremors, and arrhythmic in like in chorea, Bellism, and tics. Is it sustained or non-sustained? Sustained is continuous muscle contraction is there. That is sustained. That is dystonia, rigidity, oculogyric crisis versus non-sustained in others. Paroxysmal, uh, whether it is temporal distribution is paroxysmal, continual or continuous. Paroxysmal is transient, like in tics, PKD, and intermittent, like in tics, PKD, and stereotypy. And continual means there will be the movement will be present, but in between there will be intermittent pauses in between. It won't be fully continuous, and continuous is without any pauses, or it will be continuously present. So paroxysmal, continuous, Bellism, chorea, dystonia, athetosis, and myoclonus, and continuous like in tremors and myarrhythmia.
Dr.
Whether the
Hinal, can we remove this H is coming in the screen?
remove the what, sir?
One
Yes,
H
Padma.
on your slide, H is coming. Your name H, initial H is coming
How
in
to
on here.
put the
You can minimize and then restart slideshow.
now? Now it is not done, sir.
It's persistent.
Sir, your it is not visible. My screen. Now, sir.
Now it has gone. You can continue now.
Okay, okay. The fourth thing is will uh, see if the moment is present in sleep or in the awake state. If it is persistent in sleep also, like in my only few movement disorders are there, there will be persistent in sleep, like myoclonus, secondary palatal myoclonus, myokymia, moving toes, and severe tics, versus awake. All others will be suppressed during sleep. Uh, Second level is more prolonged observations. So first is at rest. Is the movement present at rest or with action? At rest, the resting tremors and orthostatic tremors, and on action, there is ataxia, action tremors, action myoclonus. If the movement is patterned versus non-patterned, uh, like a particular group of muscles will be contracting that is patterned, and non-patterned, many other muscle groups will be contracting at the same time or simultaneously. So in pattern, it is dystonia, hemifacial spasm, tremor, and stereotypy versus non-pattern chorea. Combinations of various movements like functional and tardive syndromes. Then level C is features requiring longer observations, like the speed of the movement, if it is slow, intermediate, or fast. Slow is moving towards akathisia, athetosis, versus intermediate, which is chorea, bellism, and tremors. Fast is myoclonus, and second is amplitude. Amplitude, whether it is large or small. Large like bellism and even chorea. And small is minim polymyoclonus. Force, whether it is powerful or easy to overcome. Powerful like in movement of stiff person syndrome, and easy to overcome like in dystonia. Whether it is suppressible or not. So this is the decreasing order of suppressibility. Stereotypies, tics, akathisia, chorea, bellism, dystonia, tremors, and moving toes. Vocalizations, it will happen in tics, sometimes in akathisia and dystonia also, like spasmodic dystonia. Self-mutilation, like Leishman syndrome, neuroacanthocytosis, cranial dystonias, and complexity of the movements in tics, stereotypies, and functional, and sensory component like in RLS and PLS and tics, and ocular, like in tics, oculogyric crisis, opsoclonus, myarrhythmia, and nystagmus. So, differential diagnosis of this first, what we discussed, rhythmic, irregular, and arrhythmic. In the rhythmic, there are tremors at rest, postural, action, and intentional. Then dystonic tremors, then dystonic myarrhythmias, myoclonus, segmental myoclonus, epilepsia partialis continua, myoclonus, oscillatory myoclonus, moving toes of fingers, myarrhythmia, periodic movements in sleep, and tardive dyskinesias. These are all rhythmic. Irregular is cortical myoclonus, mini polymyoclonus, and dystonic tremor. And arrhythmic is akathisia movement, athetosis, bellism, chorea, dystonia, hemifacial spasm, hyperaplexia, rhythmic myoclonus, stereotypy, and tics. Then, whether sustained or non-sustained, sustained contractions occur in like in rigidity, dystonia, oculogyric crisis, paroxysmal dystonias, dystonic tics, pseudodystonias, stiff person syndrome, neuromyotonia, congenital torticollis, and orthopedic torticollis, and non-sustained in others. Then paroxysmal versus non-paroxysmal hyperkinesias. In paroxysmal, there will be tics, PKD, PNKD, PED, then paroxysmal ataxias and tremors, stereotypies, and in continual, like bellism, chorea, dystonic movements, rhythmic myoclonus, and in continuous, there will be tremors, dystonic posturing, mini polymyoclonus, rhythmic myoclonus, uh, status tics, and myarrhythmias. Then, while which appears during sleep and disappears when awakened, there is hypnogenic dyskinesias, periodic sleep movement in sleep, and RBD. Then, persistent during sleep are secondary palatal myoclonus, ocular myoclonus, spinal myoclonus, oculofacial-masticatory myarrhythmias, moving toes, myokymia, neuromyotonia, and severe tics and dystonia, and which diminish others restore or diminish during sleep. So, which hyperkinesias are present at rest only, like paradoxical dystonias, resting tremors, or legs orthostatic tremor, with action only, like action dystonia, action myoclonus, orthostatic tremors, postural, action, or intentional tremors, task-specific tremors or dystonia, and which are present at rest as well as on action. These are bellism, chorias, dystonias, jumping stumps, mini polymyoclonus, um, and pseudodystonia tics. Pattern versus non-pattern. In pattern, there will be rhythmic contraction of the same muscle group. They are predictable movements, like in dystonias, hemifacial spasm, moving toes and fingers, segmental myoclonus, myarrhythmias, certain stereotypies and tardive stereotypy, tremors, and rest are non-pattern. Like example, chorea. Combinations of various of movements like psychogenic movement disorders and tardive syndromes, neuroacanthocytosis, Wilson's disease, Huntington's, and DRPLA dystonias. So first is I'll describe a little about each movement disorder. Um, the detail will be covered in the other lectures. So tremors, first it is the rhythmic and oscillatory nature of the movement. Classification based on clinical features. The first, the historical features like age of onset, temporal distribution, etc. Then tremor characteristic based upon the body distribution. If it is focal, segmental, generalized. Then activation conditions and tremor frequency. The associated sign, any systemic or other signs is present along with the tremors, and lab tests and etiological classification. So the tremors could be rest tremors and action tremors. The rest tremors occurs when the affected body part is fully supported against gravity and is not actively contracting. And action tremors occurs when there is active muscle contraction to sustain posture or move the affected body part. So action could be kinetic, postural, or isometric. Kinetic is simple kinetic, intentional, or task specific, and postural is position independent and dependent. So first, how to approach a tremor. First, in the history, we'll ask the age of onset, body part
Okay,
affected.
this we will cover tomorrow. Next, can you move forward?
Okay, dystonia. Dystonia is a movement disorder characterized by sustained or
So, Dr. Asta, can we have some means historical points, Dr. Asta? How to take history of movement disorder that we wanted. Acute onset, then gradual progressive, all these things. History that can you tell hyper history of hyperkinesia? Yeah, like that only, age of onset and all. Okay, you can move forward. We can discuss later on.
Sir, I'm not able to listen to ma'am. Um,
Madam, I think she's busy. So you can continue. Okay. Continue
okay.
this Tonya.
Yes. Sir, this small present like only 2 to 3 slides I've made of each. So should I continue that or start dystonia now?
Yeah, start dystonia.
Start dystonia. Okay. Um,
Yeah, start dystonia.
Sir, so definition of dystonia. Dystonia is a movement disorder characterized by sustained or intermittent muscle contraction causing abnormal, often repetitive movements, postures, or both. In pathophysiology, dystonia may occur because of four main reasons. First is the imbalance in the direct and indirect pathways of the basal ganglia. So the inhibitory pathway, the indirect is decreased and the facilitatory pathway is increased. Second is the cerebello-thalamocortical pathway dysfunction. So there will be decreased cerebellar inhibition and impaired enabling conditioning. Third is the dysfunction of the basal ganglia sensory motor network, in which there will be maladaptive sensory motor plasticity and lack of spatial specificity, which again decreases the cortical inhibition and leading to abnormal motor sensory processing. Clinical features. So dystonic movements, they are twisting nature or pull in the preferred direction, like dystonic tremor, including the dystonic tremor. They are repetitive and pattern, and they often sustain at peak severity and lessen at a given point, which is known as the null point, which may also be seen in the dystonic tremors. When only one feature is present, we call it incomplete phenomenology, and when at least two are present, then it is complete. Then dystonic postures, affected body part like neck, trunk, or limb is flexed or twisted along its longitudinal axis, not in laryngeal or cranial. This is the exception. A sensation of tightness and tracking or pulling is present in the affected part. And geste antagonistic, there is a sensory trick. In this, there is elevation of the dystonia occurs during the geste movement, usually soon after the patient performs the movement. Like for example, if the patient is her neck is turned to side, and if he keeps his finger on the forehead, then it will cause elevation of the dystonia for some time. But the duration of this gesture, it slowly wanes in effectiveness spontaneously before it ends. It could be simple, natural, or elegant, but never forceful. Does not push or pull the affected body part, but simply touches it, which is sensory trick, or accompanies it during elevation of the dystonia. And it requires present of all these features to call it sensory trick or just antagonist. Mirror dystonia. At least three different types of repetitive tasks are performed at slow and fast speed in non-affected limb. For example, um, uh, while writing, like we'll ask patient to write or and observe the dystonic limb. It will have posturing during that time. Uh, this is the video. So in this, the right hand is dystonic. And when we ask the patient to write with the left hand, slowly the right hand will have that abnormal posturing. So now here, this is flex at the wrist and at the fingers also. Overflow dystonia. In this, the dystonic movement or the dystonic posture extend beyond the commonly involved body region, and unintentional muscle contraction then accompanies but is anatomically distinct from the primary dystonic movement. Like for example, if a patient is having, again I'll see this in the video. I'm sorry, this is a small size. But here, when he is trying to right hand is dystonic, so when he's trying to do a movement with the right hand, his mouth will open. See, here his mouth is opening. So there is no dystonia in the mouth, but while doing a movement with the dystonic hand, his mouth opens. This is overflow dystonia. Phenomenology of dystonia. So prominent features that are they are relatively longer duration compared to macular. Macular is sudden and brief, and coriform is dance-like movement. Yeah, and this is longer duration. Although short duration contraction can also occur. There's a simultaneous contraction of agonist as well as antagonist muscles. There is a twisting of the affected part, and there is continual contraction of the same muscle group known as the pattern movement. So what we see is body distribution. temporal pattern, movement characteristic, task specificity, modifying factors, and associated features. First, body distribution that I'll cover later also. Is it focal, segmental, hemidystonia, multifocal, or generalized? Um, Temporal, is it constant or intermittent, or diurnal fluctuation is there? Is it task specific or paroxysmal? Then movement characteristics, if is it sustained or intermittent, repetitive or pattern, tremor-like component, or mirror movements or overflow is there or not? And task specific, is it during writing, performing a specific task, or playing a specific instrument, or playing only playing table, playing trumpet, etc. Modifying factors, is it getting better with the sensory tricks, just antagonist, or are there aggravating factors like stress and fatigue? Are there associated factors like pain, tremors, blepharospasm, and speech disturbances? So this is the usual progression of the primary dystonia. Usually, earliest phase, it affects the focal dystonia. Most of the adult onset dystonia plateaus at this stage. Then next stage is the contagious side gets involved. There is segmental dystonia. Many adult as well as juvenile onset, they plateau at this stage. And third is it becomes multifocal or generalized. Most of the childhood onset dystonias goes to this level. And next is the dystonic movements or postures. They are more severe and interfere with the function. And the sensory tics are usually effective in the first two stages, but when it becomes very severe, then it is not effective. And dystonia classification, it classified on axis 1 and 2. One is clinical characteristic and second is based on etiology. So clinical characteristics, it is divided into age of onset, body distribution, temporal pattern, and associated features. And age of onset, it could be infantile, childhood, adolescent, early adulthood, or late adulthood. And body distribution, focal, segmental, multifocal, generalized, or hemidystonia. Then temporal distribution, that is disease course, is it static or progressive? And variability, is it persistent? It is action specific, diurnal, or paroxysmal? And associated features, like is it isolated, combined with other movement disorders, or having other neurological or systemic manifestation? So based on etiology, this axis 2, based on etiology, based on the nervous system pathology like degeneration or structural lesions, and inherited or acquired. Uh, Inherited based on autosomal dominant recessive or X-linked recessive or mitochondrial, and acquired, it could be perinatal brain injury, infection, drug, toxic, vascular, neoplastic brain injury, and functional. And idiopathic, it could be sporadic or familial. So based upon the body distribution, focal, only one body part is affected. For example, blepharospasm, oromandibular dystonia, cervical dystonia, writer's cramp, etc. So this is cervical dystonia, which is focal. And this is just antagonistic. Now again, after some time, it became dystonic. So it doesn't, the sensory trick doesn't work for long. In segmental, two or more contiguous body part are affected. Typical like blepharospasm with either lower facial or jaw or tongue involvement, or bibrachial. And multifocal, two non-contiguous body parts are affected. And generalized is at least two other sides are involved with the trunk. And generalized form and hemidystonia, one side of the body is affected. This writer's cramp. So here, while writing, there is flexion of the at the wrist, and the way she's holding the pen, and also there is adduction of the thumb and flexion of the fingers. This is segmental. So shoulder as well as oromandibular and facial blepharospasm is there. Oromandibular is also there and shoulder is there. Is hemidystonia. One side of the body is dystonic. Right side, neck, hand, leg. This is generalized, where everything, including neck, upper limb, trunk, legs, all is getting involved. Classification based on temporal pattern. So it could be persistent. This describes dystonia present throughout the day with roughly the same intensity, which is persistent. Paroxysmal. It is self-limited and typically induced by a trigger. After the episode, the patient returns to the previous neurological state, like in PKD. Diurnal fluctuations, like dopamine responsive dystonias, they they have will follow circadian rhythm and action specific. They are only present while executing a specific task like writer's cramp. Then classification like associated features, it is isolated or combined or complex. Isolated will be DYT 1, 6, 25, 24, 25, that is TOR1A, TAP1, and ANO3, etc. Combined with Parkinsonism or myoclonus or chorea. Parkinsonism is like associated with DYT Park and myoclonus DYT 11 and complex dystonias. Uh, these are the clinical features uh, given. Sir, should I read this or continue further?
Yeah, you can take over.
Yes, sir.
No, you can continue.
Isolated dystonias, DYT1, TOR1A, it is childhood onset, autosomal dominant, mostly generalized, and here starts with focal, then becomes generalized, and DBS is effective. Six, in this, it is adult or childhood onset, autosomal dominant, usually affects the neck, limb, orofacial, and larynx. Also, these DYTs are DBS beneficial, and others are combined, like with associated with Parkinsonism, like DYT3, DYT PARP TEF1, adult onset X-linked, orofacial neck and limb and trunk dystonias are there, and these are also DBS beneficial. These are important DYT5A and B, which are dopamine responsive dystonias. They are DYT5A is autosomal dominant, and this is autosomal recessive 5B. The both are childhood onset and limb and trunk and orofacial dystonias are present. They have diurnal variations. They are dopamine responsive. There is spasticity, and there may be there is cerebral palsy in 5A and spasticity in 5 this associated with ocular gyric crisis in 5B. These are also both DBS beneficial. Then combined and with myoclonus DYT11, which is childhood onset autosomal dominant. Then in this DYT11, this is myoclonus is alcohol responsive. So this DYT11 is alcohol responsive myoclonus. It is also DBS beneficial. And complex dystonias it describes syndromes composed of dystonia in conjunction with other neurological or systemic presentation, like for example Wilson's disease, degenerative diseases, heavy metal metabolism disorders, NBI, storage disorders, mitochondrial disorders, etc. And some important myoclonus like DYT11, alcohol responsive, may develop psychiatric symptoms and stabilizes in adulthood. And paroxysmal dystonia, uh, uh, it could be chysogenic, non-chysogenic, or exercise-induced. So this is a table. In paroxysmal chysogenic, Mostly the age of onset is 5 to 15 years. It is autosomal dominant. Duration of attacks are less than 5 minutes, and it could occur 100 per day or once per month. Along with the dystonia, there could be chorea or epilepsy also, or bellism also. Sometimes it is there. It is asymmetric. Ability to suppress the attacks is present, and it is induced by sudden movement, startle, or hyperventilation, fatigue, or stress. And medical therapy, we give phenytoin and carbamazepine, barbiturates, and acetazolamide. In a PND, age of onset is less than 5 years, autosomal dominant. Minute to hour duration of attack is there. Frequency is 3 per day to 2 per year. And again, there will be mixed movement disorder like chorea, dystonia, ataxia. And suppressibility is present and induced with alcohol, caffeine, exercise, or excitement. And we treat with clonazepam. And PD, age of onset is exercise induces 2 to 20 years, and autosomal dominant. Duration of attack is 5 to 30 minutes. It could be one per day or one per month. Dystonia and chorea could be present, um, precipitated with exercise, stress, caffeine, or fatigue. Then access to your inherited dystonias are autosomal dominant are DYT1, 5, 6, 11, and 12 are associated with Parkinsonism, and NBI, DRPLA, Huntington's, autosomal recessive or Wilson's, PCAN, PLAN, then PARC2, and metabolic disorders. X-linked are Leishman, and mitochondrial leak syndrome, Leber optic atrophy, and dystonia. Acquired perinatal brain injury, like dystonic cerebral palsy, delayed onset dystonia, infections like viral encephalitis, SSP, HIV infections, or other autoimmune causes. Drugs like levodopa, dopamine agonists, neuroleptics, anticonvulsant, and calcium channel blockers. Then toxic like manganese, cobalt, etc. Vascular like ischemia, hemorrhage, and aneurysms, neoplasm, like brain tumor and paraneoplastic, brain injury like head trauma, and functional. Investigations will rule out acquired cause like for that neuroimaging, and PET scan for paraneoplastic, blood investigation like metabolic panel and genetic testing. Usually, if a defined clinical diagnosis is there, then we go with the targeted panel. If it is negative, then we go for whole exome sequencing, and if it is negative, then whole genome sequencing. And treatment, medical treatment, we give with levodopa, levodopa if it is dopamine responsive dystonias, and anticholinergics, baclofen, tetrabenazine, anticonvulsants like carbamazepine and PKD, muscle relaxants like benzodiazepine and other relaxants like tizanidine, and uh, clozapine and botulinum toxin. These are the medications. And specific pathogenesis directed therapies we can give, like for example Wilson's. If that is Wilson's, then we'll treat for Wilson's, and then a dopamine responsibility with a levodopa. Then if there is gluten deficiency, that ketogenic diet is advised. PKD will give carbamazepine. Dietary interventions, again like gluten deficiency, ketogenic diet will be given. Homocystinuria, vitamin B6, and dietary restriction of methionine will be there. Then vitamin supplementations like biotin, coenzyme Q, and vitamin B6. Trigger avoidance mainly stress, fatigue, sleep deprivation. Like in PKD, sudden voluntary movement or stress, startle, sleep deprivation or fatigue will be avoided. Like in PND, no alcohol, caffeine, stress, chocolate should be avoided. In exercise, avoid when possible excessive exercises. Then rapid onset dystonia, Parkinsonism, and then avoid when possible excess emotional or physical stress, fatigue, alcohol, etc. This is general this focal dystonias, if there is too much of contracture or too much of dystonia botulinum toxin can be given, then rehabilitation. Uh, DBS, like isolated dystonias, we can go with DBS if the medical treatment, after the medical treatment fails, or in the dystonic storm also. First, initial supportive treatment will give the trigger avoidance or treat the infections. First, we give in the first 24 hours, we first give the oral medications like triaxamine, phenydyl, benzodiazepine, or dopamine depleters like tetrabenazine. And uh, then ICU admission. And if with the oral it doesn't stop, then we'll give sedative treatments like midazolam, propofol, barbiturate, anesthesia, or paralytic agents, and surgical treatment includes DBS. In the special cases I've discussed previously. Thank you.
Oh, okay. So there was one question. Does overflow dystonia involves contiguous part rather than non-contiguous?
Usually it will, it in the definition it is given, it affects the some other part of the body. Whether contiguous or non-contiguous is not given, but during the movement, the other part of the body will be affected, which is not dystonic.
Okay, Dr. Asta, you're online?
Yes, sir. So I think it was a comprehensive discussion. So it was a nice presentation, Dr. Enel.
Thank you, ma'am.
Regarding that question, overflow, basically, as it is described, that it is the motor overflow that is seen in dystonia. It is basically the unintentional muscle contraction, okay, which accompanies but has to be anatomically distinct from the primary dystonic movement. So that is the characteristic that has been mentioned, that it has to be anatomically distinct. If a person is having in a hand dystonia, then anatomically it should be a different site. Contiguous and non-contiguous is not necessary, and it is the characteristic that it will occur at the peak of the dystonic movement. Okay.
Okay, ma'am.
Okay. Anything else you want to mention or any other things?
Dr. Hinal, I have sent you one PDF. There is one approach to hyperkinetic movement disorder. You just mention that, then we'll start next.
Uh,
Approach to
so,
hyperconnected. Should I read
Yes,
it,
thank
sir?
you.
so once I'll
Uh,
summarize regarding how to approach that.
yeah, just project it, then madam is there to summarize.
I think all who are exam going students, for them, remember you will get one case presentation on movement disorder, whether it's a hypokinetic or a hyperkinetic. Okay, so I'll be speaking mainly from clinical point of view, from your practical exam oriented point of view. Like whenever you get an exam, a case of hyperkinetic movement disorder, so the main thing is your description of the movement. Okay, that will define what you are actually talking about, and everything else will then fall into place accordingly. Okay. So, for example, when you're going to talk in history about that movement which is occurring, so what all points do you think? Like after all this presentation, okay, we'll not go much into the theory, that definitely you'll have to read, but how to approach in exam. So, what is your what is your approach, thought process regarding that? What all will you see in history? Anyone who can answer? Anyone who wants to answer this? Hello,
Yes, ma'am.
Dr. Hinal, if
Yes,
anyone else wants to answer. If in exam you get a case of hyperkinetic movement disorder, then in history, how will you proceed while describing that movement so that you are able to convey to the person, to the examiner, that yes, this is a movement. You're not going to say in the history that this is a patient of dystonia or chorea. This is not you're not going to tell that in the history. So from your description of the movement, it should be very clear to the examiner that yes, you are talking about this type of movement. Okay, so what all points will you tell in the history and then in the examination that it will be clear to the examiner what you're talking about. So anyone who can answer that question? Dr. Heenal?
Um, Ma'am, first we'll ask the age of onset, then whether it is jerking movement or it is not jerky, and whether it was rhythmic or non-rhythmic. Then is it stopping in between, or it is continuing throughout the day, or there are pauses. Then the body distribution will ask which all body parts are getting affected. Um, then if it goes away in sleep, or it is persistent, or whether it is occurring during any task, or is it at rest or with action. Then any aggravating factors, uh, associated factors like pain. Yes, ma'am.
Okay.
Any history of head injury in the past, or uh,
Okay, that will be the it for the etiology part. But
yes,
as you were telling, those are the points that you were telling for the description of the movement. Okay, first we'll tell about those points that will describe that movement so that it's very clear that yes, we're dealing with dystonia or chorea or tremor or myoclonus and so on. Okay, so first you'll have to describe that movement, and then for the etiology, you will mention all those histories that you are.
yes,
Okay, so first I'm
yes,
talking about the type of movement when we have to do that. So that points that you told were right. Anything else that you can tell to characterize the movement?
ma'am.
Two, three more points that you can tell. Okay, so like you can tell about the speed of the movement.
Yes,
Okay,
yes, ma'am.
about the frequency. For example, if it's a tremor, then whether it's a low frequency, high frequency, intermediate, depending on that also we classify that.
Yes,
Okay,
ma'am.
so frequency, the speed of the movement, then the amplitude and the force. Okay, that also is important. For example, hemibalancement. So that is having a high amplitude. Okay, that's a
Yes,
high
ma'am.
amplitude movement. So from that also you are able to tell that yes, it could be hemibalancement. So every
Yes,
movement that you'll describe has, like you have projected here also. So every movement that you will, the every description that you will give of that movement will help in describing that exactly. Okay, so it's very important what how you take mention in your history about each and every aspect of that movement. So that's very clear. Okay, because it has to be based on the history and then the examination. But first, from the history itself, it should be clear, yes, that you're dealing with a dystonia or a tremor and so on. So every when you are going to describe every aspect that you told just now and we have discussed, so like that you have to tell point wise so that it's very clear that yes, we are dealing with this. Okay. So this is the first thing that you have to describe the movement very clearly. Then second thing which you have to do is for the etiology, like you were saying. Okay, so how will you then proceed for that? What all things will you keep in your mind while taking a history?
uh,
And one more thing in that history which you forgot was diurnal variability. Okay,
that I
that
told, the dopamine responsive dystonia is diurnal variation.
is so that also you have to mention your history itself. Okay.
Yes,
Then
ma'am.
another thing was that it has started in which region of the body. Okay, that extent you have told which look body parts involved that you have told that is okay, but it has
Huh.
started from where that is important. Why?
Um, it will tell about the if it is we are dealing with genetic isolated ones, or like for example, if it is childhood onset, then
Right.
it will start with focal and then it will become generalized. But in the adult onset, it might not, it might plateau. And also in neurodegenerative, in the late adult onset, if it started with leg dystonia, then we have to think about neurodegenerative disorders.
No, no, that is one aspect. But more importantly, you have to remember that the childhood onset dystonias, they usually begin distally.
Okay,
Okay. Whereas
okay,
if it is hand or cervical dystonias, this is how the adult dystonias usually begin. Okay. And then both of them later can generalize. That is obviously there. But the onset from which region they have started may also give you a clue that it is a childhood onset or an adult onset dystonia.
okay.
Yeah, so that is also important. Then next, what else can you take in the history for etiology part?
Uh, is there any was there any history of head injury, or is there
Right.
any self-mutilation like thing, or
Okay.
suppressibility? Not
Okay.
etiology, but one bit.
What
Uh,
else? See, basically, obviously, you'll have to take a family history. Okay. If there's
family
any.
history.
Okay. Then another thing is birth history. Okay. Because birth trauma. Okay. Birth trauma, asphyxia. Okay. Connectors. All these also can lead to dystonia. Okay.
Yes, ma'am.
That you have to remember. Okay. Then past history of encephalitis or head trauma or local trauma. Okay.
Okay, ma'am.
So that also can be a cause. So matlab, that also can tell you about the etiology if there
Yes,
is any
ma'am.
trauma or local trauma. Okay. Encephalitis. So it may be related to that. So that
Yes,
is an
ma'am.
important thing. Okay.
Yes,
So
ma'am.
these are some of the points that you have to take a comprehensive history. And then obviously you'll have to look for signs in your examination to again reach to the conclusion about the various aspects of the dystonia, whether it's a whether it's about the type, classification, or etiology. Okay.
Okay, ma'am.
Yes. Any doubts still here about the history part? Are you clear? What all we have to take?
Yes, ma'am.
Okay. So can you tell what is the difference between dystonic tremor and tremor associated with dystonia? Or anyone else who wants to answer? Anyone who wants to take that question? Can anyone tell what is the difference between dystonic tremor and tremor associated with dystonia? Dr. Hinel?
Ma'am, dystonic tremor, there will be um, excessive voluntary movement, like while holding the pen, they will be squeezing the pen. Uh,
No.
exactly, I don't know, ma'am.
See, whenever we use the term dystonic tremor, it means that the tremor is occurring in the body part where there is dystonia. Okay, in that same body part, there is a tremor. Okay, like for example, a
Okay,
person is having heart tremor and that is associated with dystonia in that only hand
o-
itself. Okay, that is a dystonic tremor. But when
okay,
it is a tremor associated with dystonia, so for example, a person is having a hand tremor and associated with that, there is a cervical dystonia. Are you understanding?
okay,
They're different body parts.
okay, ma'am.
So then you will say it is tremor associated with dystonia. If in the same body part you're having this, then it is known as dystonic tremor.
Okay, ma'am.
Okay. So this is an important terminology also which you are asked. Okay. Then what else
So,
in your
ma'am,
examination?
does
Yes.
it point towards any specific etiology if like both of them?
No, see, it is because that will be a tremor and a dystonia. They're two different movement disorders that you're dealing with.
Okay,
Okay.
okay, ma'am.
And
Got
so
it.
that will have a different context, okay, and a different
Okay.
meaning, then you'll have to evaluate differently.
Okay, ma'am.
Okay, but if you are having a dystonic tremor, then there is a different differential diagnosis because your approach will change.
Yes, ma'am.
Okay, so that is the only thing that you should, and your terminology also should be accordingly correct. Okay,
Yes, ma'am. Yes.
and can you tell the age for the telling whether it's early onset or late onset? In a generalized way for dystonia, what age do we say?
Generalized usually childhood onset, ma'am.
No, I'm asking age.
Uh,
At what age you will say that yes, it's early onset or now it's late onset for dystonias?
12 years. Ma'am.
No, anyone else? Anyone who can tell whether it's a early onset or late onset dystonias? What age do we consider generally for dystonia? It's 26 years. Okay.
26, ma'am.
Yes. So early onset is before that and late is after 26 years. So that is a broad classification for early onset versus late onset dystonias. Okay.
Yes, ma'am.
Then in examination, what all things will you see again for typing that movement? Yes, that it is dystonia versus others, and also for the etiology. So remember in this way always, whether you're taking history or examination, just remember this. Okay. That you have to first tell about what is the movement you're talking about. That should be clear from your history and examination, and also the etiology and other aspects of that movement disorder. Okay. So examination, anything else you would like to see for this uh, classification and etiology part? Anything else that is missed in history that we want to see in the examination? See, in the examination, you have to see one is rest or action dystonia. Okay. Because action dystonia will be commonly the earliest manifestation of the primary dystonia. Okay.
Okay.
So one is that. What else will you see in examination?
Uh, is it patterned twisting movement, worsening with voluntary action?
Yes. So what all we took in the history that we are going to again confirm in your examination. Okay.
Yes, ma'am.
Then other clues in examination that you'll get will be Parkinsonian features if they are there. Okay.
Hmm.
Then is there any oculomotor abnormality that is being there in that patient? Okay. Then
Hmm.
is there any optic nerve or retinal disease that is there in that patient? Okay. Any peripheral nerve involvement is there or not? Any bulbar involvement? Okay. Any
Okay.
ataxia? All these things will help you in telling the etiology. Okay.
Yes, ma'am.
For example, like you told about self-mutilation. So
Hmm.
what is the possibility if that is one of the things in that?
Neuroacanthocytosis.
Okay. Second.
Hmm. Speaking.
Okay. In the eyes, what will you look for in a patient?
KF ring
Yes.
will see for Wilson's.
Right. One is KF ring. Anything else that you'll see?
Oculomotor apraxia will see for this uh,
That's all.
AOA.
Okay. What else? In which one will you find oculocutaneous telangiectasias?
This HLH or Osler. uh,
See, in ataxia telangiectasia, you can find oculocutaneous telangiectasia as well.
yes,
Then, in Parkinsonian features, can you tell what are the differentials if there's a Parkinsonism with dystonia? What all differentials will you have?
sir, ma'am. PSP or CBGD.
Okay. What else?
Rapidly progressive dementia like CJD.
Okay. See, you should always have a list, okay, because of differentials. That is the most important thing that you'll be expected. Okay, once you have to tell the summary after your history part, then you'll have to
Hmm.
summarize your case after examination. So in both the times, you'll be asked to generate a list of differentials. Okay, so after
Hmm.
history, you should be very clear that what differentials you're dealing with. Then after examination, your differentials will narrow down. Okay, so always
Yes.
after examination, you should have reach to 2 to 4 differentials on an average. Okay, sometimes it can be more, sometimes it can be a less. Okay, so that is what is the general approach that will be expected in any case that will be given to you, long cases that you'll be given. So after whenever you are taking history, you should have always points in favor and against. The examiner is going to ask you that, okay, what is the point in favor of PSP in this patient? Okay, so you should
Hmm.
be clear that yes, it is Parkinsonism with dystonia, which are favoring, then these, and so on.
Parkin acquire genetic cause like DYT Park.
Okay, yes.
And
Huntington's, Wilson's, okay,
hunting. Yes.
multisystem
Yes. Yes.
atrophy, Parkinson's itself can have both the things. Then
Hmm.
NBIAs that are there, then rapid onset dystonia, Parkinsonism syndromes that are there. Okay, so they are all dystonia plus syndromes. Okay, then SCA3 can also lead to this, GM1 gangliosidosis can lead to this, and so on. So this is how you have to generate the differentials, and that will only tell you how comprehensive you are able to approach. Okay, because this, like you have told in the presentation, but how you have to apply is the most important thing. This is the
Yes.
most common mistake that is happening in the exam. Okay. So
Hmm.
that is what you should understand, that how to approach in a exam, in a practical exam is very important.
Yes, ma'am.
So these are some of the points that I've told that you should always keep in mind whenever you are taking history and examination. So what you have to do is take a good history. Yes, this is the movement for the etiology. These are the things that I have asked. You have clarified, yes, this is the movement with these probable differentials after history. Then you'll examine, confirms those points which you have taken in history. Look for some more additional things like your oculomotor signs, which we discussed just now. Then optic nerve, peripheral nerve involvement is there or not? Parkinsonian features, ataxia, any organomegaly for storage diseases, any self-mutilation, any myoclonus, any deafness, KF rings, all these things, then you will see in the examination. So after examination, you get any positive or negative signs, then you'll again list differentials. That after examination, these are my differentials. And again, you should always remember that whenever you're telling any differentials, you should always have points in favor and against. Okay, it's not that yes, this is because that yes, this is there, so this is this disease only. No. Every disease, there'll be for every differential, there'll be points in favor and points in against. This I'm not telling for this. Any exam case that you're presenting, this is a general rule. This is what will be expected out of you to present. No one will expect that yes, you give the diagnosis that yes, this is this only. You should always tell yes, these points in this patient are in favor of this diagnosis, while these points are against this. Is it clear?
Yes, ma'am. Yes, ma'am.
So this will help you in each and every exam case. Okay.
Yes, ma'am.
Okay. Can you tell some of the red flags will tell you that yes, this dystonia is not primary?
Abnormal birth history, any perinatal insult or
Okay.
developmental delay, then any drugs which are going on or infection, uh,
Right.
then um, any like Parkinsonism, features of uh, um, this late
Okay.
onset with features of bradykinesia, etc.
Okay. What
And
else?
bulbar involvement.
Yes. Then or any organomegaly. Okay.
Yes.
Then how will you investigate such a patient of dystonia?
Mm, Based on the history and examination, we'll narrow down if it if we are thinking of any secondary cause, then we'll get MRI brain and done. If any paraneoplastic, then PET scan will get done, and If metabolic cause suspected, then metabolic panel, like storage disorders, etc. Then genetic testing.
Okay. What else?
Eye examination for KF ring.
Yes.
Then
Another?
Nerve conduction studies you can do if you're
yes,
suspecting
for
peripheral nerve
peripheral
involvement.
neuropathy, yes, ma'am.
Okay. Can you give 2 examples of diseases which can lead to peripheral nerve involvement with dystonia?
Uh, Ma'am, spinocerebellar ataxia or even neurocutaneous this neuroacanthocytosis.
Right.
Uh,
Okay. So are you clear now? Like in this way only you'll be asked in your exam.
okay, ma'am.
Okay.
Yes, ma'am.
Any doubt regarding the history and examination which you want to clarify? Because see, the theoretical part you'll have to learn, okay, that this gene is
Yes,
associated with this dystonia. Those things you can do from your book itself. But for the discussion part, the main problem is the mistake most commonly which is done is how to approach and present in your exam.
yes, ma'am.
So you should be clear about this aspect, how to approach it clinically. So if you have any doubt in that, you can ask. Is it clear to everyone about the approach? Clinically in your exams, how you have to approach a patient? Okay, sir, I think so everyone is clear about this.
Yeah,
If you want to ask,
your
then you
next
can ask.
presentation, we can upload Dr. Dhanya.
Yes, sir. Is it visible, sir?
Yes.
Yes. So we'll start. I'm going to discuss. Good evening, everyone. I'm going to discuss about the approach to chorea. So today we'll get to see what is the definition of chorea, pathophysiology, clinical features, how to approach and differential diagnosis and the treatment. So first of all, chorea, it is a hyperkinetic movement disorder that it derives its name from the chorea, a Greek term for the dance. The term chorea is in medicine dates back to the Middle Ages when chorea sanctivity or dancing mania occurred during the Black Plague epidemics. So chorea consists of involuntary, irregular, unpredictable, brief, jerky movements that flow randomly from one body part to other body part. So as we already discussed 2 days back about the basal ganglion anatomy, so I'll just go to the normal basal ganglion circuits. We have a direct pathway, indirect pathway, and a hyperdirect pathway. Direct pathway is a facilitatory and indirect pathway is an inhibitory pathway, and even the hyperdirect pathway is also inhibitory pathway. This is normal one. So what happens in chorea is normal. There is a decrease in the STN function, which will cause which will not produce the excitatory to the GPI. So finally, the inhibitory pathway inhibitory pathway will not be effective. So the facilitation will happen, or the GPI also will be overactive, so that also will cause the facilitation of the direct pathway, or substantia nigra pars compacta also will be more, which also cause the final facilitation. So as one of the most commonest seen in the chorea is the Huntington disease. In Huntington disease, the neuropathology per se is neuronal loss and gliosis in the cortex and striatum. So that is where we see the atrophy of the striatum. So there will be early loss of this medium spiny neurons, medium-sized spiny neuron, which is present in the uh, uh, substantia nigra, GPE, SNR, and GPI. this loss of this large striatal interneurons also will be lost, and loss of these neurons in substantia nigra, internuclear inclusions and dystrophic neurons in the cortex and striatum. So which will cause in the reduction of the multiple neurotransmitters, peptides, and receptors. So what happens is in HD there is a expanded CAG repeats, which will cause the mutant HTT, this cause the transcription dysregulation, translated as an expanded polyglutamine tractor in HTT. This mutated HTT is cleaved. This caused decrease in the chaperone proteins and synapsin 1 and proenkephalin muscarinic acetylcholine receptor 4 dynamin 1. So which cause the N-terminal fragments aggregates in the nucleus and axons, finally which disrupts the axonal transport and synaptic transmission. So this causes the mitochondrial dysfunction and immune activation, and cell dysfunction, apoptosis, and cell death. So this is I'll discuss the Huntington's later in detail. So first, going into the phenomenology for the chorea, to describe the chorea, it's an involuntary, random, purposeless, unpredictable movement. It is usually brief, abrupt onset. It is freely flowing between body parts, and in some we can see it is partially suppressible. Can involve any part of the body. Amplitude and frequency can vary. Usually in fingers and the forehead, it is a small amplitude, and in limbs, trunk, it is in the high amplitude, which affects the daily living. So mild chorea, we have few clinical challenges if it is very mild. In chorea patients, if it's very mild, it just looks like a fidgetiness or restlessness in the initially. Or parakinesia means they try to bend into the purposeful movements. Like when they have the arm chorea, they try to hold the adjust the glasses. So this is called parakinesia. In subtle, if it is very subtle, it is best observed with the shoes or socks removed, legs or feet suspended. And other things we can see is motor impersistence. It's a common symptom, like the dropping of the objects from the closed hand. And this can be detected by tongue protrusion test. When we ask to open the tongue, they will not be able to, patient is asked to open the tongue, keep the tongue protruded out. It retracts involuntarily due to the superimposed chorea. This is also called as thrombane tongue, darting tongue, jack in the box. And also it can also be detected by the milkmaid grip, based on the inability to keep the fist in a sustained tight grip. And they also have difficulty in maintaining the eyelid closure. So this is one of the video. So we can see the free-flowing, irregular movements of the right hand and right leg. And she also have the facial and this one is milkmaid grip. When trying to hold, she's not able to inability to maintain this squeezing of the. So other signs we see in the chorea are hung up sign and peduncular reflexes. Probably this is caused due to the motor hypotonia. And the gait we see in this chorea patients, it is usually an irregular gait and dance-like gait. Also other gaits which we can see in neuroacanthocytosis, we can see rubber band gait, and in Huntington's lurching gait will be seen. And this chorea can also be interfere with the respiration, phonation. It is presenting with slurred speech or involuntary vocalizations like grunting, humming. So based on the distribution of the chorea, it can be present. Till now we spoke about the phenomenology. Based on the distribution, we can know the causes also. So facial or forehead, orobuccal lingual, hemichorea. So First going into the orobuccal lingual chorea. This is the coriform movement of the mouth and the tongue. Most common cause is tardive syndrome. This is referred to as tardive dyskinesia. This is seen in the dopamine receptor blocking patients who have taken dopamine receptor blocking medications. And careful review of the medicines and the recent medication exposure should be taken to if we have this orobuccal lingual chorea. And other conditions where we can see is neuroacanthocytosis, chorea acanthocytosis, or McLeod syndrome. In chorea acanthocytosis, this orobuccal chorea can also have they have tongue dystonia while eating dystonia. While eating, they will not be able to. The food will be pushed out. And other conditions where we see is neuroferritinopathy, paraneoplastic syndromes like NMDA receptor encephalitis, Leishmanian syndrome, acquired hepatocellular degeneration. And chorea can also be overlapped with the dystonia, which is seen in chorea acanthocytosis, Leishmanian, and hepatocellular degeneration. And in chorea acanthocytosis, I've already told, feeding dystonia will be there. Forehead chorea. Forehead chorea, it is a subtle coriform movements which is present in the frontalis and eyebrows. So this is not a pathognomic, but which helps us to distinguish from the other conditions. In HD, it is seen in Huntington disease. So Huntington disease patients also have the psychiatric complaints. So they may be on dopamine receptor blocking medication. So they have this tardive dyskinesia. So, but in tardive dyskinesia, we may not see the forehead chorea. So that helps us to distinguish the HD. So hemichorea. Hemichorea is a like we will see on the hemi is one side of the body, hand and the leg. So classical causes were contralateral subthalamic nucleic lesions. Other possible lesions are contralateral basal ganglion, thalamus, corona radiata, and temporoparietal cortex. Etiologically, most common cause is vascular, and other causes which we see is non-ketotic hyperglycemia. Usually in non-ketotic hyperglycemia, it is seen as hemichorea hemibalismus syndrome, infections, and tumors. Important diagnostic step, any patient who is having acute hemichorea, if they have, even though they not have the diabetic history, first thing is to check for the glucose and to rule out non-ketotic hyperglycemia. Chorea may persist for weeks, even after the glucose, weeks to months, even after the glucose correction. So, and the differential for this hemichorea or asymmetrical chorea without brain lesions is the other conditions we can see is Sydenham's chorea and polycythemia vera. So, so approach to the diagnosis of chorea. So whether it is an inherited or acquired, whether it's a childhood onset or adult onset. So we need to acquire a careful family history. If any family having the similar history or other, they can present with other phenomenology also, may not have the same. So we have to elucidate the family history properly. And time course, whether it's acute, subacute, chronic, and whether it's a static, paroxysmal, or progressive. Usually acute and subacute will be acquired causes, and this slowly progressive or non-progressive chorea, usually it goes into the genetic etiologies. If timeline is unclear and they have a subacute presentation, we have to consider autoimmune and paraneoplastic causes. And after getting this history, we have to definitely get the other comorbid history and examination features. So other examination like cerebellar features like peripheral nerve involvement also is equally important. So but if going into the time course, chorea time course, if it's acute, subacute, if it's sporadic, if it in adults, the most commonly it is autoimmune. Metabolic is the most common, structural, metabolic, autoimmune, infections, and drugs. If it is children, we have to consider the Sydenham's chorea. And if it's chronic, more than 1 year, genetic causes seen. And adult, it is Huntington's disease, C9orf72 disease, SCAR17. And in children, benign hereditary chorea. So classification of chorea, as we told, in the chronic developmental and aging choreas, it can be a physiological chorea of the infancy. Cerebral palsy or kernicterus can cause, and brain buccal oral lingual dyskinesias and dentilux orodyskinesias. In older adults, senile chorea, but I think this is not told. The recently more senile chorea have been diagnosed with the Huntington's disease. In hereditary choreas, Huntington's disease, benign hereditary chorea due to TITF1 gene mutation, neuroacanthocytosis, and other central nervous system degeneration such as HDL like and DRPLA, and spinocerebellar ataxia, ataxia telangiectasia, ataxia oculomotor apraxia type 1 and type 2, tuberous sclerosis of basal ganglion, NBIA. This in NBIA, PCAN is mostly seen, and neurometabolic disorders such as Wilson's, Leishnian, lysosomal storage disorders, amino acid disorders, Leigh disorder, and porphyria. And drugs such as neuroleptics can cause the tardive dyskinesia, anti-Parkinsonian drugs, amphetamines, cocaine, tricyclic antidepressant, and oral contraceptives. And the other acquired causes like toxins in alcohol intoxication, withdrawal, carbon monoxide poisoning, which can cause the hyperintensity, which can MRI also we can see as hyperintensities of caudate and globus pallidus, and manganese, mercury, thallium, toluene. In metabolic, as I already told about the hyperglycemia, which can cause hemichorea, hebebalismus, hypernatremia, hyponatremia. Even the hypoglycemia can cause pregnancy. Pregnancy also shouldn't be missed. Chorea gravidarum and hypoparathyroidism, hyperthyroidism, acquired hepatocellular degeneration, other nutritional causes such as B12 deficiency, pellagra, beriberi. In infectious causes and post-infectious causes, Sydenham's chorea, encephalitis, and even the CJD also they may have. Usually they'll have myoclonus. Along with that, they may have chorea. Immunological like SLE, Hinoshino's purpura, sarcoidosis, Behçet disease, polyarthritis nodosa, and vascular. Often it is present as a hemichorea. It can be either because of infarction or hemorrhage, and or AV malformation, moya disease, and migraine also sometimes can present, polycythemia rubra vera, and other conditions like tumors, trauma, including subdural and epidural hematoma, and so as I already told, structural causes, infectious, and the acquired causes are structural, infectious, autoimmune. Autoimmune we have to consider in elderly, the SLE, APLA also can have, and metabolic and endocrine causes, hematological polycythemia vera, pharmacological drug induced, and others we have discussed. So we have to differentiate the we decided, we know it is a chorea. We have to differentiate it from other movement disorders. So dystonia. Usually dystonia, it is an involuntary sustained muscle contraction and abnormal postures that are repetitive pattern, twisting, and sometimes tremulous. These are generally slower chorea, and this may occur with rest, may occur at rest, typically triggered by voluntary actions. Unique features are elevating maneuver, like if they have we can reduce with the sensory trick and have the mirror movements, which is not common to the chorea. In myoclonus, whereas myoclonus, it is a brief lightening like jerk. It is the quickest movement of the body part and can produce ranging from approximately 50 to 200 milliseconds. It can be caused by a muscle contraction, either positive or a sudden interruption of the muscle activity, negative. Whereas chorea has even the chorea also has fast movement fragments, but unlike in the myoclonus, the movements occur together with the slower movements. In myoclonus, we won't see this, this quality causes the flowing quality, like fast with the slower movements. Tremor. Tremor, it is a rhythmic, oscillatory, predictable, and that distinguishes the tremor from the chorea, predictability. Tremors are generally classified by their location, posture, and they can occur and their amplitude and the frequency. So tics. these are also non-rhythmic recurrent pattern movements. They may also have the vocalizations. The main differential is like they have the premonitory urge to do the movement, and they have some degree of suppressibility. The tics can be either simple or complex, and they can vary from type, severity, and anatomical localization. The repetitiveness and accompanied urge and the suppressibility is the one which differentiate chorea from the tics. And balismus. This is balismus balismus is it's a high amplitude movement that usually involves the proximal part of the limbs, shoulder or hip, and it is associated with flinging or the kicking movements. And whereas akitosis, it's a lower amplitude, often distally seen. It's a writhing movement with slow, continuous flow rather than fragmented sequence. In chorea, it is a fragmented. In akitosis, it's a slow, continuous flow. Chorea may coexist with akitosis and dyskinesias. These are all general terms for all the abnormal movements. The term is more frequently used for the specifically medication-induced hyperkinetic disorder conditions, such as levodopa-induced dyskinesias or tardive dyskinesia. Chorea and chorioethetoid movements are the most common form of levodopa-induced dyskinesias. So the first thing, we go into the Huntington disease. We'll first discuss about the hereditary chorea. In Huntington disease, it's an autosomal dominant HTT, as we already discussed, and usually present in the third to fourth decade, and even usually the presentation can be depend upon the CAG repeats. Normally, less than 26 repeats will be present, CAG repeats. If it's 27 to 35, it's an intermediate range. And from more than 37, it's an adult onset Huntington's. If they have more than 70, it's a juvenile onset Huntington disease. The juvenile onset Huntington disease, also known as Westphal variant. And the most common, the triad we can see in the Huntington disease is Parkinsonism, dementia, and chorea. And psychiatric features are one of the most common initial presentation. Later they have the chorea, and later they will have the other features, dementia and this Parkinsonism. And in juvenile variant, we usually see is rather than chorea, Parkinsonism is the most common feature. Parkinsonism and seizure is the common feature we will be seeing. And in MRI features, we can see the caudate and striatal atrophy. This showing the box-like ventricles in this image. So other than in Huntington's, we have this anticipation. Offsprings present earlier or with worse symptoms than the transmitting parents due to the CAG expansion during the gametogenesis. This is much more common in the spermatogenesis. And offsprings of the affected father may have the earliest onset or present without the family history also. So Huntington disease is the most common, as I told, prodrome. It is cognitive or psychiatric signs, and subtle motor features like fidgetiness and parakinesias can precede. And anxiety, depression, irritability, aggression, suicidal ideation, impulsivity, psychosis, and OCD behaviors. And suicidal ideation is present in up to 30% of the patients. In adult onset, chorea predominates, juvenile onset, Parkinson's. Forehead chorea, as I already discussed, based on the this one, this is subtle, helps to distinguish the HT from the tardive dyskinesias. And the eye movement predominant in Huntington's, which we see is slow or delayed saccadic intrusions of the smooth pursuits. This is nothing but cogwheeling of the pursuits, and voluntary pursuit initiation impaired in the later stages, and they rely on the head thrust. And this chorea may also involve, as we already told, speech, swallowing, and respiration. And the gait which we see in the Huntington disease is wide-based lurching stride. And other phenomena which are present in Huntington's are dystonia, myoclonus, ataxia, and tics. So after discussing with the Huntington disease, we also have the Huntington disease-like copies. C9 or 72 disease. This is an autosomal dominant hexanucleotide expansion, and this is the most common HD phenotype. in white population. These people present with UMN signs, variable familial presentation. So they can have FTD presentation, they can have MND presentation, fully penetrant with genetic testing results demonstrating more than 60 repeats. Other one is HDL4 or SCAR17, autosomal dominant expanded CAG repeat on TBP. Second most common HD phenotype, the presentation will be ataxia. MRI shows caudate and cerebellum, putaminal rim enhancement, fully penetrant with genetic testing, and other conditions like SCAR1, 2, 3, 8, 12, 48. These are all autosomal dominant. The predominant clinical feature will be ataxia, and we'll get to know with the genetic testing. And other hereditary condition like dentatorubropallidoluceal atrophy. This is the autosomal dominant and expanded CAG repeat on ATN1. The most prevalent in Japanese population and also in the African American families in North Carolina. In these DRPLA, MRI shows diffuse atrophy and hyperintense periventricular white matter, fluffy penetrant with genetic testing, and this requires more than 47 repeats. Other two are like HDL1 and HDL2. HDL1 is autosomal dominant PRNP. The prominently psychiatric features, seizures, myoclonus will be seen, and MRI shows atrophy, significant atrophy. HDL2 is junctionophyllin 3 repeats, JPH3, CAG repeats on JPH3, exclusively in sub-Saharan African heritage. MRI repeats caudate atrophy, fully penetrant with genetic testing, and more than 70 repeats. And this HDL2 also show acanthocytes. Acanthocytes. In other conditions, I'll discuss later what other conditions where we see the acanthocytes. The other hereditary condition we see is Friedreich's ataxia. It's autosomal recessive FXN mutation. Typically, childhood usually may present without chorea, but adult or late onset, they will have chorea. Variable progression. The other condition clinical features they have is ataxia, areflexia, neuropathy, cardiomyopathy, diabetes, foot deformities. They have the GAA repeat expansion, abnormal nerve conduction studies. And the other one, the common other thing is these up to now, till now we have discussed autosomal dominant. From here, from Friedreich's ataxia, autosomal recessive. This chorea acanthocytosis is a autosomal recessive. The chorin protein VPS13A gene is defective. The second to fourth the presentation will be present in the second to fourth generation. The variable progression, the prominent features we see in history and examination are orobuccolingual chorea, self-injurious or oral mutilation they'll have, hypersalivation, and dysphagia, lingual dystonia, rubber man gait, and acanthocytes are present in the peripheral blood smear, and CPK will be elevated in these patients. I'm just showing a video of rubber man gait. She's a 35-year-old female who presented with psychiatric Parkinsonian features and eating dystonia. Here we can see now. And this is one more video of her eating. She was not able to eat. Whenever she eats, her tongue pushes the food out. She will use her head thrust to keep the food inside. So other one is X-linked in McLeod syndrome. It is seen from 6th to 5th decade. It's almost similar to the neuroacanthocytosis. But here we have cardiomyopathy. Cardiac involvement is more commonly seen. Seizures, axonopathy, and acanthocytes are present in the peripheral blood smear. And serum creatine kinase will be elevated. So this is the other condition where we see the acanthocytes on the peripheral blood smear. So going into the basal ganglion mineralization diseases, neuroferritinopathy, it is also autosomal dominant and present from the 4th to 5th decade. Time course variable progression. Orobuccal chorea will be there. MRI shows basal ganglion iron accumulation on T2 weighted and gradient recalled images. Serum ferritin will be low in these patients. Aceruloplasmia, plasminemia. It is autosomal recessive, present in 4th to 5th decade, variable progression. They have dystonia, ataxia, diabetes, and retinal degeneration. MRI show iron accumulation on the T2 weighted and GRE images. They have absent serum ceruloplasmin. And other one is FAR disease. It's autosomal dominant and present in onset is the 3rd to 4th decade, variable time course. Usually they can present with tremor, Parkinsonism. CT or MRI can show the basal ganglion brainstem cerebellar calcifications. And Wilson's disease, these patients are autosomal recessive ATP7B chromosome on chromosome 13q14. At childhood or early adult onset, variable response to the treatment, and they can remain stable once chelation is done, or it can be cured with the liver transplantation. Usually, they can present with gastrointestinal symptoms or chorea, dystonia, Parkinsonism, ataxia. And main features which we see is KF ring, sunflower cataract, wing beating tremors in Wilson's disease. And these patients will have low serum ceruloplasmin, elevated 24 hours urine copper, elevated liver enzymes, and elevated liver copper, liver fibrosis or cirrhosis. And MRI shows Jane Panda sign or mini Panda sign. So other one is this comes into kind of Wilson's can also be in childhood. So now going to the childhood disorders, benign hereditary chorea. It's an autosomal dominant condition present in the childhood. It can be static or slightly progression. Stable course. They'll have brain lung, and this is also called as brain lung thyroid syndrome. So pulmonary and thyroid problems will be there. They may not have the dementia. The childhood onset disease we known as adenylyl cyclase type 5. It's autosomal dominant ADCY5 on chromosome 3q. The time course will be variable, and they have paroxysmal. Childhood in history and examination, we find childhood hypotonia, facial myoclonus, worsening with sleep deprivation, and paroxysmal kinesinogenic dyskinesia. So this is with the movement they will have. It is autosomal dominant, and most common we see is PRRT2 on chromosome 16. It's childhood, paroxysmal. Episodes lasting seconds to minutes, numerous per day, triggered by a movement. They are very good responsive to the sodium channel. This one, so carbamazepine, paroxysmal non-kinesogenic dyskinesia. It's also autosomal dominant, childhood onset, and these are triggered. These are not triggered by the movement. These are mainly triggered by the stress, extreme temperatures, alcohol, or excitement. This may last for minutes to hours. So in autosomal recessive, I've kind of missed 3 conditions like ataxia telangiectasia, ataxia with oculomotor apraxia type 1, and ataxia oculomotor apraxia type 2. All these are autosomal recessive. In ataxia telangiectasia, they have the peripheral ataxia, telangiectasia, and peripheral neuropathy, and they may have the chorea along with this. And in oculomotor apraxia type 1, dystonia, chorea, and axonal sensorimotor neuropathy with or without the cognitive impairment. In ataxia with oculomotor apraxia type 2, they'll have less frequently cognitive impairment. They have later onset compared to the type 1, and they have elevated serum alpha fetoprotein. And the next, consider the metabolic disorders. Leishmanian syndrome, that's X-linked disease, recessive, developmental delay and self-injurious behavior, elevated urea in the blood and urine metabolites, glutaric acid aciduria type 1. It is also autosomal recessive. Seizures and developmental delay, dystonia will be there. And they will have 3-hydroxyglutaric acid and glutonic acid, urinary glutaric acid. Metabolites in the serum and urine and CSF can be detected. GLUT1 deficiency, it can be autosomal dominant or recessive. They present with seizures, ataxia, developmental delay, and maybe paroxysmal. And other condition is mitochondrial disorders. The presentation can be, inheritance can be variable, and highly variable clinical presentation can be there even within the family. So going into the acquired chorea, Sydenham's chorea. Sydenham's chorea is the childhood onset chorea. It is acute onset, usually present after the acute streptococcal infection. It is self-limiting. They have the tick-like behavior, irritability, inattention. History of the streptococcal infection, basically because of the molecular memory, they have the basal ganglia is affected, and they can be associated with this one, and can also be associated with chorea gravida. These patients can present with chorea gravidum later in the life. So throat cultures should be done for the group A streptococci and anti-streptolysin O antibody, anti-DNase antibody. So in adult onset or middle-aged adulthood, the other autoimmune diseases we see is SLE, APLA, often middle-aged adulthood in the context of systemic diseases or subacute primary manifestation. And other is Behçet and Sjogren's syndrome, celiac disease. They also have the other systemic relevant features according to the relevant condition. In SLE, they may have the rash, and Behçet, they may have these oral ulcers, and APLA patients, they can have present with the thrombotic events, miscarriages, and so for these patients, we have to check for the ESR, ANA, celiac antibodies, dsDNA, and anti-cardiolipin lupus antibody for the APLA syndrome. And for the even the chorea gravidarum, to rule out pregnancy test should be done. Anti-NMDA antibodies and anti-Iglon 5 antibodies in the serum and CSF. And in NMDA receptor encephalitis, it is subacute onset. Usually it's a limbic encephalitis and associated with ovarian teratoma. Iglon 5, they may also have present with Parkinson, parasomnias, sleep-related disorders, and cognitive impairment, and gaze-like paralysis. Like it usually mimic the PSP kind of pattern. And going into the paraneoplastic, we also know the small cell lung cancer, ovarian teratomas, it is adulthood or subacute. It's progressive, may be associated with encephalitis and development of the systemic symptoms. So systemic symptoms, although their neurological features may appear before the systemic findings present. So we have to check for the paraneoplastic panel like anti-HU, anti-MA, collapsing CRMP5, PQ calcium channel, and LG1, Casper, NMDA. PET-CT will be helpful to find out the primary carcinoma. So as acquired causes, as we already discussed, cerebral palsy or periventricular leukomalacia, it is present in the perinatal period. They'll have the course is stable and chronic course, and heavy body or focal chorea can be present. In ischemic stroke or hemorrhage, mainly caudate or basic ganglion involvement will cause the chorea. And demyelinating diseases and other space occupying lesions, neoplasms or abscess. These conditions can be acute or subacute onset. And if it is a space occupying lesion, they may be a slowly progressive. And para-infectious like measles, mumps, rubella, varicella zoster virus, and also torch infections, I think, and Epstein-Barr virus, tick-borne encephalitis, West Nile encephalitis, CMV, Japanese encephalitis, and HIV. So these are often associated with systemic illness or encephalopathy, unilateral or generalized, and viral causes tend to improve with the resolution of the infections. And metabolic causes, as hyperglycemia, hypocalcemia, hypoparathyroidism, hyponatremia, hypernatremia, hypomagnesemia, uremia. So we have to check for it is usually static or sometimes can be progressive with the medications, or improved once the offending agent is removed. So we have to check for the glucose, sodium, calcium, thyroid functions, and the parathyroid tests. So for polycythemia, it is usually static with toxic injury to the basal ganglion. Hematocrit is raised. And carbon monoxide poisoning or manganese mercury organophosphates poisoning, gradual improvement once the metabolic, the resolution or the exposure have been improved, reduced. So this is the patient who presented with hyperglycemia of around 450 sugars. He have hemichorea, hemibalismus. You can see on the right side, upper limb and lower limb. So we also have the drugs. So we have to take a detailed history of the drugs, where what they are on, which can cause the chorea. So antidepressants like fluoxamine, paroxetine, tricyclic antidepressants, and anti-seizure medications like carbamazepine, ethosuximide, lamotrigine, phenytoin, phenobarbital, valproic acid, and zonisamide. And antihistamine blockers like cimetidine, cyproheptadine, and the Parkinsonian drugs like levodopa, dopamine agonist, anticholinergic like trihexyphenidyl, dopamine antagonists like butorphanons, benzamides, and phenothiazines, dopamine antagonist antiemetics, psychostimulants like amphetamines and cocaine, other medications which are like baclofen, cyclosporin, digoxin, fluoroquinolones, lithium, methotrexate, oral contraceptives, steroids, theophylline, and calcium channel blockers, flunarizine, verapamil also can cause the chorea. So to work up first, once we get to the approach of the patient, we confirm the chorea and find out any other associated features they have along with the chorea, and complete neurological examination, and acuity, age of onset, family history, medication, toxin exposure. Then we will send the for all the patients. Workup is like CBC with peripheral smear, complete and thyroid profile, lipid profile, ESR, ANA, anti-cardiolipin antibodies. If they are adult onset, subacute onset, we have to see for lupus anticoagulant, HIV, vitamin B12, and nerve conduction study, because associated peripheral neuropathies can be detected. And if we suspect anything chorea gravidarum pregnancy test, and Sydenham's chorea if suspected, anti-streptolysin O, anti-DNase B, and subacute onset less than chorea of less than 1 year, then paraneoplastic and autoimmune encephalitis panel to be done. So imaging for all patients, MRI brain should be done. So going into the, shall I go into the imaging, ma'am? So shall I go into the imaging?
Yeah, you can continue.
So for Huntington's disease, this is the normal MRI where we are seeing. This is the Huntington disease. They have the severe atrophy of the caudate and the putamen, and the ventricles are enlarged. So here we also see the frontal horn width to the intercaudate distance. Usually it is 1.6. Normally it is 2.2 to 2.6. In HD it will be less than 1. And also intercaudate distance to the inner table distance. In HD, it is increased. Normally, it is 0.09 to 0.12. So here we can see the box-like ventricles. This is seen most commonly in the, this is seen in the HD. So other condition like DRPLA, here we can see hyperintensities of the lower pons, upper pons, midbrain, and white matter hyperintensities with cerebellar atrophy. This is DRPLA. And in PCAN, like we can see the eye of tiger sign. Iron subsequently accumulates with the time. This is also one of the imaging which show patchy hypointensities in the multiple deep gray matter in the caudate, putamen, and globus pallidus, and thalamus. And also show the concurrent T2 hyperintensities. PET studies at the anatomical level at which the basal ganglia interfere with the somatosensory input to the cortex is not clear. A candidate structure is the reticular nucleus of the thalamus. So basal ganglion induced hyperactivity of the reticular nucleus of the thalamus nucleus might reduce relay of the somatosensory input from the VP thalamus nuclear complex, thalamonuclear complex to the cortex. So that's what we told in the pathophysiology too, that inhibitory pathway, indirect pathway is inhibited. So the direct pathway is facilitated, which is more active. So that's why we are seeing the thalamo reticular, this shows this. And So in HD patients, this is a normal control subject. PET. This shows the persons with symptomatic HD show progressive loss of D2 receptors bearing the striatal neurons. So this is the acanthocytes. The acanthocytes are the RBCs, which are thorn-like projections. These are formed because of the abnormal lipid metabolism. So these acanthocytes are seen in neuroacanthocytosis, macleoid, HDL-like one, and NBIS, PCAN. These 4 diseases we can see the acanthocytes. So coming to the management of the chorea, once we get the history, physical examination, imaging, laboratory testing, and genetic testing done, if we know the cause, then we will start treating the cause. If it's a drug induced, remove the drug and adjust the dopaminergic therapy. If it's infection, we have to treat with the antimicrobial therapy. And metabolic cause, medical management like hypoglycemia, hyperglycemia, hyponatremia, we have to treat them. And for autoimmune, for Sydenham's, we'll go for the penicillin prophylaxis. And for APLA or SLE, immunosuppression. For paraneoplastic, identify the neoplasm, treat the primary neoplasm, and also immunotherapy, IVIG, PLEX. If chorea persists, then we can go for the symptomatic therapy. Or if you don't know the cause, if the cause is not modifiable, also we can go for the symptomatic therapy. And the symptomatic therapy in the first line, we'll have first line, second line, and adjuvant. And in the first line therapy in Huntington's disease, it's deuterobenazine, TBZ, and antipsychotics, olanzapine and tiapride. For brain lung thyroid disease, it is levodopa. For tardive dyskinesia, it's valbenazine and deuterobenazine. For levodopa-induced dyskinesia, it's better we go for the amantadine. And this PKD disease, PKD for carbamazepine, as we already told. Sydenham's, carbamazepine and valproic acid. And if the second line drugs for the HD, it is like olanzapine, antipsychotics. And for the adjuvant, we can give amantadine and clonazepam and levetiracetam. For if we are not able to treat, we can go for the surgical management, DBS with the GPI. And other targets are still under the study. For tardive dyskinesias and brain lung, this is tetrabenazine and anti-epileptics, and clonazepam can be tried as an adjuvant for the tardive dyskinesia, botulinum toxin also. And for surgically, GPI and STN DBS targets. And so for Huntington disease, if you are suspecting the Huntington's, clinical suspicion, genetic testing should be done. If it's positive, if the are the symptoms severe enough to impair the function, then then we'll go for the treatment of the conditions. Like they have chorea, we can go for the tetrabenazine, quetiapine, along with that psychosis, olanzapine, clozapine. If they have, and without psychosis, tetrabenazine and DBS is better. For rigidity and bradykinesia, levodopa and dopamine agonists. For myoclonus, valproate, and epilepsy, valproate and clonazepam. For bruxism and dystonias, botulinum toxin is better. And for depression, irritability, aggressiveness, and dysphoria, SSRIs and tricyclic benzodiazepines. And other drugs are in the experimental. If we don't get the genetic testing positive, then we have to screen for the secondary choreas or other genetic tests like HDL, like other mimics, SCA1, 2, 3, 17, HDL1, junctionophyllin 3, VPS 13A for neuroacanthocytosis, macleoids, and these conditions should be considered. So for secondary chorea, as we already told, this I'll skip, we have already told the symptomatic treatment. And so
Okay,
yes, sir.
Dr. Dhanya, can we finish in next 5 minutes?
Yes, sir. Okay, sir. This already we have discussed, sir. So neuroleptic pharmacological management is neuroleptics are frequently used off-label for the management. So multidisciplinary approach addressing the psychiatric and cognitive aspects of the neurodegenerative disease is important. This can help in the benefit from working from speech, occupational, and physical therapists, like and genetic counseling should be addressed at the myriad of the functional and social issues. Caloric demands are higher among the individuals with chorea, and nutritional consultants is helpful. Physical therapy for the balancing training and core strengthening and implementing assistive devices is helpful. Oh, sir. Thank you.
Yeah, Dr. Asta, we can have a final comment, then you can conclude.
Yes, I think it's a nice presentation. Not much time left for more discussion. One thing that I want to tell, one student had asked in chat that deafness is associated with which disease? So whenever there's a dystonia with deafness, then you can think of X-linked recessive heterodegenerative diseases. Okay. Now coming to chorea, basically again I'll talk more in the clinical aspects
Yes,
only because rest all you can read. But the
yes,
main problem that is there in your exams is how to approach. So like we have discussed the points, like I have told in dystonia that similarly the same approach is what you apply, have to apply in chorea also
yes,
because you have to tell the major points that will tell you is that it's we are dealing with chorea. Okay.
yes,
So
ma'am.
can you tell me which from which term this chorea has come up?
Uh, s- Ma'am, Saint, uh,
See, basically it has come from the Middle Ages, okay, when chorea
yes,
sancti vitae,
anti-white.
that was termed as a dancing mania that was seen usually during the
Yes, ma'am.
Black Plague epidemics.
Yes,
Okay, so from that they have taken up this term. Why? Because it mimics dancing like movements. So
yes, ma'am.
from the naming itself, you can understand what the movement may be like. So you have to be very clear that it is an involuntary thing, it is irregular, it is unpredictable, brief, and jerky, and that
Yes,
will flow randomly from one part of the body to another. So if these are the characteristics that you can be, yes, that we are dealing with chorea. Okay. What is negative chorea?
uh, ma'am, hunger reflex or uh, uh, they can have this hunger reflex, ma'am. That is also negative, and they keep losing the things, like falling. Things will be falling down.
Yes. Anyone else who can tell a better terminology? Basically, that you have told, but you have to be very clear. Basically, negative chorea is motor
Motor
impersistence.
impersistence.
Okay.
Motor impersistence.
So whenever, like for example, you have a closed hand, but there's a dropping of object. So that
Yes,
is negative chorea. Okay. No,
yes,
because there's a motor impersistence in that patient. Okay. So these are the signs that will be asked you in your exam. Okay.
yes.
So some of the characteristics, if I ask you for a chorea, what will be the phenomenological features? Can you
Ma'am,
name?
is it like milkmaid grip, thrombane tongue, darting tongue, jack in the box, bag of worm appearance?
Okay. What else will be the things that will characterize chorea? What is parakinesia?
They try to like incorporate this choric jerks into the voluntary movements, like as if they're
Okay.
adjusting their specs.
Yes. So sometimes you can find that the patient is just fidgety.
Yeah,
Okay. So it can be that subtle. So you
mm,
have to pick up that because of this parakinesia characteristic of the chorea.
yes, ma'am.
So you should have that clinical eye where you can understand, yes, that is different from fidgetiness.
Yes, ma'am.
Understanding. So it can be as subtle as that. So this is where your clinical acumen in your these things that we have discussed today will apply. Okay.
Okay,
Can you tell what is the pathophysiology, basic pathophysiology in Sydenham's chorea?
ma'am, basically, because of the molecular mimicry,
Right.
this group B streptococcal infection they'll have. They, because of the molecular mimicry, they this causes
Yes, right. There's a group A beta hemolytic streptococcus to which there's a molecular mimicry, and this is what happens in Sydenham's.
yes,
Okay, what is chorea molis?
I think they will not be able to move because of the very severe chorea. They will not have able to flaccid paralysis. They will have
Why?
because of the severe chorea.
No,
I'm
no,
not sure,
not due
ma'am.
to
Clear.
severe
I'm not
chorea.
clear. Mm.
Yeah, see, remember, it is not the severe chorea, but it is the severe hypotonia that is there.
Oh, Okay,
Okay, so
ma'am.
it is a variant of this Sydenham's chorea only, where
Okay,
there is
ma'am.
a severe hypotonia because of which there is a complete flaccid paralysis, and the patient is usually bed bound.
Yes.
So you should be aware of this term. This also is asked commonly in your exams. Okay,
One more thing I want to add for Sydenham's chorea is it is a longer duration, ma'am, compared to the normal HD patients. It is more than
right.
100 milliseconds muscle contraction
Yes.
incident.
So it will be asymmetrical as compared to
Yes,
Huntington's.
yes,
Yes, right. Okay, and in Huntington's the duration will be 50 to 100 milliseconds, while in Sydenham's it will be more than 100
more than
milliseconds.
100 seconds.
Yes. So that is one of the things. What is anticipation?
Um, In Huntington's disease, because of the gametogenesis will cause the increase in the CAG repeats. So the next generation will have the earlier disease onset compared to the previous generation. And for few
Okay,
males, they may have present even without the previous generation disease, no? Like clinical presentation.
okay. What else are the characteristics of Huntington's chorea? Genetically,
Uh,
what is happening?
Medium spiny neurons will be lost, ma'am.
Okay,
Because of this neuronal loss and gliosis in the cortex and striatum, this will be caused. And there is also loss of this large striatal interneurons and loss of neurons in the substantia nigra. So,
okay,
because of this, and there will be also this decrease in this neurotransmitters, ma'am, acetyl transferase and GABA, GAD, glutamic acid decarboxylase, decrease in the enkephalines and increase in the somatostatin, TRH, and neuropeptides, decrease in the glutamate. Yes, I
okay.
remember.
If there is a feeding dystonia, what will you think of?
Biting plate, ma'am, basically it is seen in neuroacanthocytosis, ma'am. Biting plate is suggested for them, and
Okay,
they'll also have the like lip biting and all along with this.
yes. So this will be asked. Okay, so you'll
Yes.
have to mention your history also, whether if you suspect
Mm.
such patients. Okay, then you'll
Okay.
have to mention this. Okay, because that will be one of your differentials.
Yes, ma'am.
Okay. Then if
Yes,
there is a dementia associated, what all will be your differentials?
ma'am.
Your chorea patient.
Huntington's, yes, ma'am. Huntington's disease, uh,
Okay,
and even this C9orf7 to HDD like HD phenotype like they may have other dementia features.
okay,
And,
what else?
mm,
SCAR 17. Okay,
SCAR 17 as well.
DRPLA.
As well, yes.
Okay, so this is how you'll be asked again to list your differentials. Okay,
Yes.
if there are square wave jerks, what all will you think of?
Square jerks in usually seen in Huntington's, ma'am.
Okay, what else?
Is it seen?
Acanthocytosis also. Okay,
Acanthocytes.
okay. If it is mitochondrial, then what will you say think of?
Mm, lay,
La-
lay, dis-
Lay's
lay,
disease.
lay
Yes.
disease.
Okay. If it's pregnancy, what do we give the term to that?
Chorea gravidarum.
Okay. If it is
Okay.
myoclonus with the chorea,
Myoclonus with chorea.
so it can be again CJD, DRPLA, SSP.
CJD, yes, ma'am.
Okay. So this is how we'll approach. Like I discussed in details about dystonia, I think there's not much time now left. So for chorea also, this is how the approach should be. Okay. Clinically,
Okay.
you have to find out clues in history and examination. so that you can generate a list of differentials based upon that. That is what will be expected of you in your exams. Okay?
Okay.
Anything you want to
Okay.
clarify? Is it clear to everyone?
Yeah, we can conclude the session. Thank you, Dr. Astha and Dr. Hinal and Nanya for this session. Thank you, everyone. We can conclude. We'll close this.
Thank you, sir. Thank you, ma'am.
Okay.
Thank you.